Good morning, everybody. Welcome to Pediatric Grand Rounds. The voice you hear right now is Suzanne Mazer. I'm Director of Continuing Medical Education here at Seattle Children's. And now I have the pleasure of introducing our four speakers. I will brag that all four of them are graduates of our pediatric residency here at University of Washington and Seattle Children's Hospital. Woohoo! So thanks so much to the four of you for being here. First, I'll introduce Dr. Anisa Ibrahim, who is the medical director of Harborview Pediatric Clinic and a pediatrician there. Dr. Fabiola Movius, who is a pediatrician at CMAR Community Health Clinic, as well as Dr. Christina Pease, who is also a pediatrician at CMAR Community Health Clinic, and Dr. Shaquita Bell, who, in addition to being a pediatrician at the Odessa Brown Children's Clinic and many other roles here at Seattle Children's, she's also the medical director for the Center for Diversity and Health Equity here at Seattle Children's. We'll turn over the virtual microphone to our four presenters today. And thanks so much for you guys being here. We really appreciate it.
Thank you, Suzanne. And good morning. And I will be starting us off. I'm Christina Pease, a pediatrician at CMAR Community Health Centers, and I work at one of our clinics in South Park, just there in South Seattle. In this grand round, the four of us really hope to offer you some perspective from the local community surrounding the Seattle area. We all four work in urban community health centers serving the underserved. We have not meant this to be a how-to lecture nor a training on how to be anti-racist. More importantly, we're here to share our own individual as well as collective experiences in our work and in the communities we live, really to strive to be better in caring for our own neighbors and also for the community we live in. So I do hope that we will bring this around at the end and that we can enlist all of you listening, no matter where you work and or live in the surrounding Northwest. I would like to take a little bit of time to acknowledge that the land we are now living on once belonged to Native peoples. You can use this website to map out where you live and or work to truly learn about the Native tribes to whom that land belonged prior to us coming. And my CMAR clinic is located in South Park, just south of Georgetown near Boeing Field, and it is on Duwamish land. And not uncommonly, when we can escape at lunch, we take a short walk to the Duwamish River, which is definitely still a place of sustenance for people, but as many of you may have heard, is definitely an area that has suffered tremendously from industrial pollution. I am honored to have been asked by Suzanne to speak at Grand Rounds, and I feel none of us, nor any of us, should do this work all on our own. So I have joined forces with three other women who also work, as I said, in community health centers. And to all of us and those of you who are listening who also serve the marginalized communities, all of us have been well aware of the inequities that exist along racial lines well before this COVID pandemic hit. And COVID has really truly only served to amplify the blatant and extreme health, social, educational inequities that exist in our communities. And as pediatricians, it is quite heartbreaking to see children who deserve just as much as their neighbors not able to achieve and receive. Neither of us have any disclosures whatsoever. To kind of run through our objectives for this morning, primarily threefold, but first off, we really would like to create a place for self-reflection. I'm not going to show you in my slides any specific data, but COVID is, and we all know, affecting under-resourced communities disproportionately. And we would like you to take some time right now, prior to us continuing, to just set in your mind what your intention would be on how you will move forward and address these inequities. No matter where you live and or work, COVID is here for a while. Each of us will share a bit of our personal background as well as our individual work in our clinics to highlight some of the inequities that we face, and also to share with you our practice as well as our organizational objectives to try and address these on a day-to-day basis. And really, we really want to encourage this to be done in a very strengths-based way. And also, as we turn it back to self-reflection, really in a way that you can transform yourself, do the learning that you need to do, and bring it back into your practice so that we can all move forward in a more socially responsive way. So I was born to a Francophone Chinese mother who grew up primarily in Vietnam. And my father was English speaking from a very conservative New England family. And I also happened to grow up a mile from where George Floyd grew up in the 3rd Ward in Houston, Texas. I definitely remember the occasional gunshots that I could hear from my bedroom window, and I was indeed zoned for the exact same school that George Floyd was. However, I grew up in a small, tiny, multiracial community of university professors, and I was afforded opportunities to attend an international private school, receive most of my education in French, and subsequently was able to learn Spanish quite easily, as well as growing up in privilege, able to travel, and then start my career in medicine, really to bridge barriers. I returned to Houston for medical school, and that is probably when it hit me in the face, what privilege I truly had been afforded and what I had been spared as I rode in the ambulance and cared for my neighbors at our trauma center, many gunshot victims. And I am grateful, I will honestly say, for not just being white. I'm grateful for being biracial. That was a journey for myself. But I also really have come to recognize this year what the amount of white privilege that I grew up with, and that I have truly used one of my marginalized identities, my darker skin, my features, to shield myself from responsibility for speaking up. And I have asked myself why, after 7 years of working with a marginalized Latino community, why it is only now that I am speaking up about the systemic inequities that exist. So I'm grateful to be here and really trying to be better, learn more, and also join forces. I just want to make us all aware. Many of us as pediatricians are familiar with Odessa Brown and might be familiar with Harborview's Children's Clinic within the trauma center in the hospital. CMAR and many of the other community health centers that are listed here truly practice on a family practice model. And I have been with CMAR for the past 7 years. And as I said, mostly underserved. Our particular clinic where Fabiola and I work serve primarily Spanish-speaking families whose children are on Medicaid. But what I have learned over these past 7 years working alongside family medicine colleagues is how fortunate we are as pediatricians that all of our children have access to a healthcare safety net by being on Medicaid. Even though we fight barriers 80% of the time, just trying to get them services and get them on wait lists, there is tremendous work that is being done beyond once these children turn 19. And I will admit, and many of you can share these feelings of just being very tired, but also since COVID hit, I will admit to some resentment and some anger, as just yesterday in clinic, I'm scotch taping a child's surgical mask inside my level 1 surgical mask because we have run out of proper level 3 masks. The only ones we do have available are those rigid dust masks, which really aren't sustainable to wear all day. Our clinic really is only 20 minutes from Seattle Children's and from where I live, and we have an ant problem. We have clocks and toilets that don't work. I've had to send children to the emergency room with a cardboard splint. So at times I do feel extreme fatigue and anger and wondering why, where we have so much need, why we are really struggling, and our MAs are buying their own PPE. But that's where my work lies, and that's where joining forces, I feel we can truly make this better. As I said, this isn't a lecture on microaggressions or on how to be anti-racist, but I ask you all to take some time prior to labeling, prior to expressing thoughts that the next patient you have, because they don't speak English or because they have no-showed multiple times, that these are people, they are not social train wrecks. and to really kind of go beyond assumptions and imagine what trauma or what might be their story. This young 14-year-old came in to see me just last week, or it was last month, for a well child check, and he was not unlike the picture you see there, which is from an art exhibit in El Paso. But truly, many of us might be a little threatened to run into him. But he really opened up and teared up as to what kind of assumptions had been made just based on his appearance and his past track record. And where I really struggle a day in, day out is multiple well checks where I run into a 4-year-old or a 3-year-old little girl, little boy who really haven't developed their speech in the way we need them to. Yet they were born in Seattle. They were born in the same hospital my children were born in. And I still can't comprehend how they haven't been connected to resources. This is something that kind of blows everything out of the water when you realize that children living not far away are really left in the dust. I've started working more with children with autism, and of all of my 30 patients, I would say one has been able to truly access ABA, applied behavioral analysis therapy. And that's our evidence-based therapy. That is, and all these other children are really not getting any of the services they need. So I need help, they need help, but this is where I truly want to raise our awareness and ask, what can we do to join forces to share this load and to get these children where they need to be. So this slide is primarily my current mission statement when I walk into a room for a well child visit. It doesn't matter what screening tool you use, it's just making sure it is culturally and linguistically accessible to the family you're serving, and that they're in a ready place to talk about it. And I can't stress enough how underutilized early intervention services are across Washington state, or perhaps maybe just in my practice in my community. For any child under 3 where you have any concern, even if their screenings have come back normal, or the parents are just stressed, is tap them into this system of support, because that will set them up for success in preschool and then further get them ready for school. I have worked to become certified in order to capture autism at an earlier stage and really try and hit the tip of the iceberg and address the long wait list that exists. But I also need help with that. We only get 15 minutes per visit. And I empower my families to navigate school partnerships, writing letters to help them realize they're right in learning about their child's IEP. But there are learning disabilities that go beyond what schools can help and support and diagnose, one being dyslexia. So any support for neuropsych evaluations or dyslexia diagnoses, or anything that we can partner with that is typically in the private sector, one child at a time can really make a difference. And that's where I've been trying to reach out, multidisciplinary, talking to early intervention groups. So I've left my email there. And last but not least, just to give you a quick highlight, Dr. Gomez-Movius will discuss a little bit more specifically what CMAR has done for COVID in our community. But CMAR has been around for quite a while, started with the migrant farm workers, but truly has a breadth of service that is multifaceted and covers from birth, pregnancy, all the way to the elderly. And I'm honored to introduce to you Anissa Ibrahim, who is the medical director at Harborview Children's Clinic.
Hi, good morning. Thank you, Christina. So as Christina said, I'm Anissa Ibrahim. I hope to use this slide just as a quick overview of who I am, and I think what factors have really led me to be very passionate about this work. As many of you guys know, I am an immigrant. My family came here as refugees from Somalia, and we were raised in South Seattle, a place where, as I grew up, I really saw that it was the social determinants that really determined our health and our well-being, and many of those factors were just simply outside of our control. But I had a great childhood in South Seattle, a place where I still live, in a place where many of my patients or families are living and are from. As Dr. Mazur said, I did residency at Seattle Children's Hospital, and I'm now at Harborview. So the Harborview Pediatric Clinic is a clinic that's very near and dear to my heart. And one of the reasons is that's the clinic where I grew up as refugees. That's where we established primary care. And that's the clinic where I spent my childhood. What I felt most there, being a child in that clinic, is the fact that that hospital and the providers were very mission driven. I did not feel like we were at the poor hospital when we were getting primary care there. It felt like we had people who were focused on those who have been marginalized. And I think words are really, really important. Although I don't like that word marginalized much, I think it shows that it's something that is done to a community and not something that the community does to themselves. And then also those from under-resourced areas. I think addressing racial inequities is something that Harborview's mission and, by amazing team at Harborview would always like to do, but it requires getting uncomfortable. It requires uncovering what structural and non-structural inequities exist, and it requires really addressing them head on. And that is a place where I think most people have seen does not feel good, but it's work that needs to be done. At Harborview, we have an incredibly diverse patient population, which we are, very honored to be caring for. We have language access, and I cannot stress how important, delivering excellent care in a language that the patient feels most comfortable in, how important that is, but also the cultural navigation piece. Our cultural case mediators program has been critically important in keeping our families, especially those who are newly arrived to the United States, healthy and feeling like they are champions of their own health. We have the Refugee Health Promotion Program with that Dr. Beth Dawson-Hahn and Susan Park-Borstein have been really critical in securing partnerships so that we can care for newly arrived medically complex refugee and immigrant families. Through Dr. Abby Grant's hard work, we have a focus on developmental screening. Like Dr. Peace was saying, our children of color are at risk for having delayed diagnoses and, a lot of lack of follow-up, ensuring that they are getting the services that they need. And this universal screening with patient navigators that families love and trust in partnership with Child Haven has been really critical in addressing that disparity. Our Casa de los Amigos program is a partnership with Office of Refugee Resettlement, where we see unaccompanied asylum-seeking minors. And in a time where they are fearful and a lot of rhetoric has not been supportive of these youth, I think it is, such an honor to be able to care for them and really ensure that they get good care while they are at the shelter. We are the first foster care center of excellence with thanks to Dr. Dylan Waters' hard work. And I think that becoming a primary care center for foster care children will allow us to really focus on those children of color who are in the foster care system and really also address and advocate for the issues that got them into the foster care system to begin with. Our Reach Out and Read program is similar to the programs that many other clinics have, but we have worked really hard to ensure that our children feel represented in the books that we are handing out to them. Representation really matters, and it's very meaningful to promote literacy, but with a book that is meaningful for both the child and the parent. And really, advocacy at every level is something that everyone at the clinic strives to do. So while there are many ways to address inequities, I'm going to use the COVID-19 pandemic as a case example for the events and inequities that we addressed at Harborview. I will say my disclaimer to this is that a lot of this work was really done by my wonderful colleagues in the pediatric clinic. I was on maternity leave when COVID really increased, and they did such a phenomenal job caring for our patients and making sure that their voices were heard on behalf of and in conjunction with our patients. Our approach at Harborview was multi-level, and it really started with the data, which I'll get into, advocacy and action, which is important, centering community, and then last but not least, reflection and constant reflection, really. So data, I think, is really important because while many in the media were calling COVID-19 the great equalizer, I think anyone with any ounce of information working out on the ground knew that it was not a great equalizer, that there were going to be disparities that we were going to see, that were going to be consistent, and that were going to fall across race and ethnic and language lines. So the national data revealed racial and ethnic disparities with infections and hospitalizations and outcomes, but the language data was not readily available. And those of us who were working with limited English proficiency communities and families knew that this data was important. One, to evaluate, but two, we needed this for advocacy at multiple levels. Now, we were concerned about what, our families specifically that lied at the intersection of many of these racial and ethnic disparities, but also language disparities. Now, a group at Harborview that included Dr. Bell and Dr. Dawson Hahn, Dr. Park-Gorstein, Dr. Johnston really said that we need this data and really held UW Medicine's feet to the fire to say that it's our responsibility to have this data available. And the data showed what we already knew. Right, that there were disparities across language. Now, it's one thing to have a perception and for doctors who care for these communities to say that, but it's another thing to really have it on paper. And this slide was from April, and by then we already saw that if you spoke a language other than English, that sometimes the positive infection rate and then also negative outcomes were sometimes twice as much as the English speaking population, which is just absolutely unacceptable. And then when we look at this data, it's important to look at what information is being gathered and how accurate is it, right? We saw early on that the way that this data was being collected was not complete. Right. And in some communities, specifically the Somali community, which I'm a part of, I know that 9% is not actually correct. But what we're actually seeing is how many people mark Somali as a language on that data sheet, right? And that is probably a smaller number. This is also at a time where testing was just not available to our communities. And Dr. Mobius will talk about that in a little bit. So with that data, we really looked at advocacy and action. And this was in real time. All of these things were happening simultaneously, but it was really, really important. And it was helping address the inequities across racial, ethnic, and language lines. So the language data really allowed us to push for increased number of translated resources into multiple languages in real time. And I don't think anyone didn't think about not doing it, but I think it really allowed us to say that every single document that comes out in English needs to come out in these languages that we see are suffering, right? These communities that we see are being put at a disadvantage because they're not getting information that's critical to their health. We were also pushing for faster translation times from the community partners. We heard the brochure comes out in English saying that there's a Wednesday clinic, and then we get the Spanish version on Wednesday morning. That is a disservice, right? So many community organizations were translating fast in real time for free. And then those were being used across, across many different platforms by the same organizations that were putting out English flyers. So it was essentially free labor on communities that were already struggling and leaving other communities out. So it allowed us to push for that. On a clinic level outreach, I cannot stress how phenomenal the providers and the residents in the clinic were. They put together a list of resources and called each and every single one of our families to check in on them, to check in on their well-being, to see if they needed resources. And because our clinic volumes were so low, this was the time to really connect with our clinic, with the patients in our clinic, but also our community. And then while we were kind of really jumping head into telehealth, again, for our community, telehealth is not a straightforward process. And we were very concerned about the digital divide and the racial and language inequities that going full-on telehealth without stepping back to address barriers were. And Dr. Park-Gorstein and many others actually partnered with clinics across Harborview that cared for populations similar to ours, but also with the UW School of Medicine to see how can we connect families so that we can address the barriers of the digital divide, the literacy barriers, the cultural barriers for telehealth. And then while we had thought through all of our perceived barriers for the community, it's really important to understand that unless we center the community and take ourselves and our egos out of thinking that we know what's best, we really won't hear the full story. And while we had felt pretty good about addressing many of the barriers, it was when we sat with the community that we found out about other barriers or other issues that were happening. Now, this quote is from a mom that was listening into one of the our community conversations about COVID through the Somali Health Board. It was a Facebook Live event. And she said, every time I hear someone telling me something about COVID and what to do and how to do it, I nod and I say yes to everything I am told, but then wonder, how am I supposed to do any of this? It was through the community conversations that we realized so many, I think we realized it, but it really brought forth that so many of the recommendations that we were putting out were rooted in privilege. It was a privilege to have a room to isolate in. It was a privilege to be able to not be an essential worker. It was a privilege to not have to go to work. It was a privilege to do many of the things that we were simply recommending. And then families were starting to feel ashamed of, saying, I don't have a room to put a person in. I don't have another bathroom. I don't have access to masks. And that was leading to further marginalizing our own, pushing away our own populations, because we were not, we were pushing recommendations that were so rooted in privilege that families were not willing to push back against that anymore. It was, through these conversations that we realized that the communities told us a multi-generational household is such a beautiful thing for all of our communities, and it is now being demonized by everyone. And it does not feel like, it's being acknowledged how important this is to our families and our communities, because now it's all of a sudden a no-no. And then it was, again, through conversations with the community that we realized that contact tracing really elicited a lot of PTSD in families who had been through war and trauma, to be called by someone, to be traced where you went, what you had done. And especially when these contact tracers were not from the community and there was no built trust. So I think it was a good reminder that if you are trying to address any inequity, you really do have to continue ensuring that the community is at the center. And then finally, I think with all work, and especially this kind of work, addressing inequities, it's really, really important to continually reflect and learn from what we have done and learn from specifically our mistakes. And I think it's always important to ask, where are our blind spots? What do we know? What is being pointed out? What did we learn? And then who was not at the table? And, many people say, make sure you're bringing the community to the table. What I have learned to say is that the community is the table. And if their voices is not being represented, then that table needs to just be thrown away, and we need to restart. And I think with really needs to have to be at the center, and we need to be the ones inviting ourselves with permission to that table so that we can learn and grow. Thank you. With that, I'll turn it over to Dr. Mobius.
Hi, everyone. I want to start by introducing myself and telling you a little bit about how my background informs my work. My name is Fabiola Mobius. I was born and raised in Mexico City, and I came to the United States at the age of 10 as an undocumented immigrant. This is a photograph of me all the way to the left with my family, and the reason why I usually share this photograph is because my family was living in a garage at the time that this photograph was taken, shortly after we arrived here. I graduated from the University of California, Irvine with a dual MD and PhD degree in 2016, and I participated in the program in medical education for the Latino community while I was there. I graduated from the pediatric residency program at Seattle Children's in 2019, and I am currently a proud pediatrician at CMAR Community Health Centers, which, as you know, is one of the largest federally qualified health centers in the United States. Next, I want to highlight some of the barriers that my colleagues have already discussed this morning, and in particular by discussing a very specific local perspective. This would be our CMAR's response to COVID-19 and community testing. On March 16th, 2020, CMAR created a COVID response team, which was primarily made up of family medicine residents, nurse practitioner residents, as well as family medicine physicians and nurse practitioners. And Dr. Peace was also a part of that response team. And we were trying to put in place workflows to address testing in the community because there was such limited access. On April 24th, CMAR was recruited by the Seattle and King County Public Health Department as a community testing site. CMAR was asked, in particular, to use workflows that already were in place, primarily as a result of the COVID response team and all of their work. And we were asked to form a partnership to expand community testing. They offered us PPE if we needed it. But this photograph right here is a photo that shows what the outdoor testing sites look like. So you could drive up in your car, it could be a drive-through, or you could walk up to one of the tents and be tested, which speaks to addressing barriers of access, because many of our patients don't own vehicles and they use and rely on public transportation. So if they needed to be tested, they would come on a public bus, walk right up to the testing site and be tested and then get their results. I think another barrier that CMAR is very proud of addressing is that of maintaining access to care. I think this is probably the one that CMAR is most proud of, because at a time early on in the pandemic when places were shutting down and care was only being offered in emergency situations, CMAR wanted to switch to other models of care and to give the message that everyone was welcome and that they would not be considered an infection risk, that we would provide care in whatever way we could. And that's how the outdoor COVID-19 testing sites were born. The digital divide that Dr. Ibrahim was talking about is very real, and there's a substantial racial and ethnic difference in broadband adoption. White adults are much more likely than either Black or Latino adults to report having a broadband connection at home, and 25% of Latinos are smartphone-only internet users, and so that means that they lack traditional home broadband service. So advertising for these clinics was mainly done through radio and social media through Every 1360 AM, and it was also done with advertising. This is an example of a flyer that was put up on our social media websites as well as our own website and put up on all of our clinics in English and in Spanish. This is, I'm going to talk about the community testing that I did in action. Towards the end of May 2020, there was a significant drop in visits at CMAR, and the pediatric population was most affected. So I found myself with my first job out of residency, and there were no patients for me to see because no one was coming to clinic. So on June 3rd, community testing started at the South Park Clinic, which is where I work. And clinic leadership approached me and asked me if I wanted to take part in these clinics. And I am fully bilingual, and I absolutely said yes. And in conversation with my colleagues last week, I think one of the things that is really true about community health centers is that all hands are on deck. Everyone contributes in whatever way we can, and I am most proud of using all of my experience and all of my skills in whatever way I could to help out my community. So the photograph on the left is early days when I first started testing. I am in a bunny suit with a shield, and it was extremely warm. This is early June, so by the time that it was like mid-July in the mid-80s, it was extremely hot. And the before photo on the left and then the after photo on the right, I think it's really difficult to tell, but I'm picking up my scrubs off of my body because I am completely soaked in sweat. I mean, my socks were soaked, like everything is soaked under that bunny suit. So it was not easy work. And I'm really proud to have stood out there with my fellow nurse practitioners and my fellow family medicine doctors. One of them came out the day before her retirement, was out there testing. I'm extremely proud of this. You know, we are gonna do whatever we have to do to test our community. Just a brief look at the numbers. CMAR currently offers outdoor testing at 17 medical sites in 8 different counties. What I mean by outdoor testing, the photographs that I showed you. As of November 2nd, there had been 15,126 COVID-19 tests completed at outdoor testing sites and a little over 1,000 positive tests with 51 pending results. And, you know, I think the most important part of what I want to talk about today is inequities in representation. So the community testing outdoor clinics mostly use point of care antigen tests and not PCR tests. This becomes important because disease case definition is only by PCR tests. And in order for cases to be included in the official counts in some health departments, a PCR test must be performed. When I started testing in early June, turnaround time for PCR testing was 7+ days. Sometimes patients did not get their test results until 14 days after they had been tested. as my clinic director told me, this becomes clinically and epidemiologically meaningless when there are a 3 to 5 day window of maximum infectivity. Many of our families after the pandemic lost their jobs and relied on a single person to go out there, work, earn a living, to feed their families. So this person could not get back to work. It was damaging to the entire family. So CMAR addressed this by switching largely to point of care antigen tests to get results within 20 minutes. And this allows us to not notify the families and the patients the same day they are tested. It's very important to note that there is no reporting of these positives and there is no contact tracing. So no one's going to call the families and let them, ask them questions about where they are, it's all us. We do follow-up phone calls and it's the medical assistants. It's us when we're out there doing the actual testing and talking about counseling, who lives with you, do you live with any immunocompromised individuals, do you live with any pregnant patients, do you live with anybody older than the age of 65, and guiding them through what might be a higher risk situation, and then following that up with phone calls after they've tested positive. It's as far as we've gotten because no one is going to call these families to try to advise them. So this is my last slide, and the point of reflection that I want to leave you with, this is the COVID-19 cases among King County by race and ethnicity as the most recent data. And I want to ask the question, how are resources going to be allocated to our communities if we are not being counted, right? So if point of care tests, which we're mostly doing, are not counting towards these counts, how are we going to do this? It's important that I say that some of our clinics are using both PCR and point of care antigen tests now. And it's important to note that as the pandemic has progressed, point of care testing turnaround times, PCR test turnaround times have improved. So they're no longer 14 days, they're more like 3 to 4 days now. But still, this is something that I think when we look at these numbers, it's important to think about. And next, I'm going to pass it over to Dr. Bell.
So many of you on the phone call, I was just looking at the participant list, know me very well. My name is Shaquita Bell. I'm a pediatrician at Odessa Brown. And I identify as she, her, but I also identify as Cherokee and Black. And working at Odessa allows me to serve families that are much like the community that I come from as well. I like to joke that everybody's an immigrant to my family's, to my mom's family's point of view. But in all seriousness, Odessa is facing a lot of the similar issues that my colleagues here have brought up. We had issues around launching telehealth and the digital divide. We had issues about securing PPE and how do we serve our community in a meaningful and equitable way. But I'm actually not really here to talk about Odessa. I'm going to be a transition point from my 3 colleagues in the community to start to push you all about what we can do in terms of inequities, especially focusing on COVID. And when the 3 of us, or the 4 of us met, one of the things I mentioned to them was how tired I am. Most of you on this list have heard me speak and have heard me talk about racism in so many different places, from national conferences to local talks. And I start to feel a little bit repetitive, a little bit redundant. And I hope that people don't think that listening to a talk, coming to Grand Rounds and hearing about what's going on in the community is enough. I don't want anybody to leave this conversation and think, okay, I've done my good deed for the day or the week or the month. I'm aware that racism exists and I'm good, I can move on. So my portion of this talk is going to focus a little bit more on you. And yeah, I'm talking to you, whether you're on the phone or watching on video. I'm going to give you some tools, some information, but I'm going to circle back to the intention that we all were asked to set at the beginning of the talk by Dr. Pease. What are you going to do to address the stark inequities in our community? And I'll talk about some tools and some things to keep in mind to do that, but then we're hoping at the very end to have some moments where you all can share what you will do, and of course, any questions you have about how to do this. So as you have heard about these champions in our community, these amazing community health centers and FQHCs that are in the community, are of the community, and who are serving the community, you've heard many wonderful things happening. You've also heard many opportunities and gaps that could happen. But you've also heard a little bit about some of the impacts of COVID, of health inequities, and I would argue of racism and xenophobia. So I want to take a few minutes to talk about something that really drives those theories home for me and what I notice in the care that I have the pleasure of providing at Odessa, at Harborview, and at Seattle Children's. So if I was only given 1 minute and one slide, this would be the slide that I picked. I cannot tell you how many e-feedbacks I've read, how many code purples I've heard about, how many families I've talked to who have been cared for at Children's, who've experienced blatant racism and discrimination because of the way they talked, the way they looked, the words they used, the tone they used. And I believe that as a clinician, it is my job to set aside my personal feelings, to set aside whether this person likes me or doesn't like me. It's not really my job to make people like me. My job is to make people healthy. And so I like to put this lens of trauma-informed care on and say, and help me understand that when people are swearing, or when people are yelling, or when people are aggressive, that usually that's a sign of that bottom right box of flight and fight, and that this is a trauma response. And if I can think in my clinical brain, if I can put that lens on and say, this person experienced trauma at some point in their life, and these are the tools that they've learned to survive when they are threatened. And what is a bigger threat than having your child be sick or your family member be sick? Then I can take my personal feelings out and understand that this person is literally trying to survive this moment, or trying to help their family members survive this moment. It has absolutely nothing to do with me as a person. It may have a lot to do with how traumatizing an experience in the medical system is, and how much those experiences mimic trauma, such as being asked to take all your clothes off and being spoken to in a language that you don't understand, and sometimes even in a different language than the person who's speaking to you speaks. That this is a trauma response, and that it is my job as a clinician to set my personal feelings aside and put that clinical lens on to say, this story doesn't make sense, but maybe it doesn't make sense because this person doesn't know how to tell it. And this is the trauma response their neuronal pathway has made in order to survive. Or this behavior isn't a bad behavior or good behavior. This is a behavior that has helped this person survive, and start to think of those things as really being strengths in the family and the community that we serve. And the number one way to get through an experience like this is the top right, in my opinion, is to give agency back, to make this a shared experience. As Dr. Ibrahim said, to have the community be the table. So the patient and family in front of you gets to share in the decision making, and that I'm not the end all be all person in this room, that really they are. I get to spend 20 minutes with them once a year, but the family, the community are the ones who have the strength and the resources. I'm going to go over this one a little bit quickly. This is just a reminder that if you experience trauma at a young age, when your neuronal pathways are being made, then those neurons, instead of coming together to meet, are going to form different pathways. And that's not, again, not a good or a bad thing. It's just a fact. And that trauma happens when you're young and your brain is developing. That is going to lead to those pathways for the rest of your life. And you can learn new pathways, but it's just a reminder to us that both a parent and a child may have experienced trauma and have their own unique trauma response to that. So as I mentioned, I hope that you all don't walk away from this talk today thinking, okay, I'm done. I've done my part. This is good. All these wonderful doctors told me about what's going on and now I'm aware and we're done. It's really not easy work to start addressing these things. And I really want everybody to take a moment to look inward, to reflect internally and personally about what they can do themselves, and then go back to the systems in which you work to work on those things. Courtesy of Dr. Ibrahim, I like to use these buckets to think about how we impact change. So this is not necessarily, this does involve individuals, but I like to bucket it and say, like, when we are trying to impact change, we need to impact knowledge, we need to impact attitudes, and we need to have policy support. So all of these things need to happen. Some might happen first and second, and some might happen at the same time, but every one of them needs to happen. And you can think of really great examples like bicycle helmet use or vaccine hesitancy, that we can add policy like requiring an MMR vaccine or requiring helmet use for motorcycles or scooters. But we also need to inform ourselves on why those things are important. And all of that work can help us impact attitudes around wearing helmets or getting vaccines. And that's the same with serving families in the community, in addressing anti-racism and addressing xenophobia. So this is again sort of an internal lens. These are the things you can start to do by educating yourself, raising your awareness, reaching out, reflecting on what your beliefs are, what your biases are. But then I also think that you could strengthen, or you can keep going, Christina, that was fine. You can strengthen your own connections to the community, that you can work in partnership with communities, as Dr. Ibrahim said, having us at the table. Dr. Movius is a really great example of being of the community and working with the community. Focusing on things like language is very protective against systemic or institutional racism and xenophobia. I added a couple of examples from Native communities connecting back to language, to ceremonies, and to equine therapy are really protective for rebuilding around trauma and for being resilient at times of extra stress like that we have right now during the pandemic. But there is some pitfalls. Again, I mentioned wanting to help you all focus inwardly. There's a couple of things I'd like us to try to avoid. One is this idea of us versus them. So when I speak of community, I use the word we, and I don't want to use terms like them and those people or this group, because that really others us, that really separates us as a community. And I believe in this current climate that the thing that we need to hold on to the most is our shared humanity, and using language is really important to do that. The second bullet, we had a really nice discussion amongst the four of us about this idea of model minority or exceptionalism or extraordinary. So when there's a negative stereotype, attributing that that stereotype to an entire community versus one person seeing an individual who's successful as an exception, as an individual, instead of representing their community. And that's a really slippery slope. And we were all talking as a group about how many of us have really faced that. And me personally, like how many times I've been asked as a Black and Native woman, how have you been able to be a doctor? And that comment is always sort of a slap in the face. I mean, I get it. It's kind of a compliment, but it's also really just like a slide to the rest of my community. I also think that you all have heard me talk about centering whiteness a lot, and I just want to put another push out there to try to avoid that. So that's another thing that exceptionalism pushes towards, the idea that the more white, quote unquote, white that you are, the better or more exceptional you are. So this is my second to last slide. This is just an individual model of how to be an anti-racist. And like Christina said, that's not what the point of this whole talk is, but I wanted to share this resource. And then the next slide is how to help an organization be anti-racist. And you'll have access to these slides. And I just wanted to have that resource on there. But now that we're at 8:50, I would love to go to our self-reflection slide, I want us to remember that intention that we set. I want us to think about what have you heard today that might have shifted that intention that you set at the beginning, or how your intention has developed over this talk. And then I hope that you'll think about how you can be accountable, how you can be held accountable for equity and for anti-racism work in whatever daily, day-to-day work that you do. How can you respond when somebody brings an equity concern to your attention? How can you meet that discomfort with basically, like, how can I be more interested in learning? How can I be more comfortable with receiving feedback and not immediately be defensive? And then I hope that you'll take time to take the things that you learned today forward and push yourself to learn more and to do more. So I'm going to stop there, and I hope that people, if they have questions, that they'll share them in the chat, but that if you would also be willing to be courageous and share what your intention is as well. I like a good silence. Everybody's rapidly typing. That's what's happening. I can see who's on too, so I could call on somebody. Any questions? Anybody willing to share an intention? All right. Al, thanks so much. I'm gonna read for everybody. Because there's a lot of people on the phone. So Dr. Bell's comment on trauma response and people yelling made me think about the yelling that is coming from the hardline Trump supporters, including my own family, who are absolutely lovely people that I enjoy being with. Despite my strong disagreement with much of what they have to say, it is clear that there are a lot of people who share their opinions, and they spoke loudly in the last election. I do believe in many cases that they have experienced trauma, the trauma of growing up in a racist household, as I did, where the N-word was a common part of everyday language. How do we approach our response to them so that we can find common ground? Acknowledging my own racism in this question. Oh, thanks so much for the question. I think that is such a good point, and I'll let my co-presenters answer as well. But I would love to say that I've been reading Ibrahim Kendi a lot in the last couple of weeks. I've read 2 of his books, How to Be an Anti-Racist and Stamped from the Beginning. And I think that's the crux of this work, is understanding that racism is everywhere, that it is like the Matrix, it exists, and you are either being anti-racist or you're not. But the point is that racism being everywhere means that it hurts all of us. It is not just the people of color. It is not just Black people who suffer from the harms of racism. We've demonstrated today that it's not just Black people, because there's people who speak other languages and who identify as other cultures who are also suffering the consequences of racism. But importantly, white people suffer from the impacts of racism as well. And so this issue of racism impacts all of us. And if we can take that lens, if we can think about that when we're talking to somebody who has an opposite opinion of us, it's sort of like that trauma-informed model that I shared, that really helps us start to understand where the other person is coming from. And if you all can agree on some sort of common ground, like we want to talk about what's best for this country, or what's best for our nieces and nephews or our grandchildren, then you can build from that common ground and start to understand each other from a more separated place of then just taking things personally.
I really like what you said, Shaq. I think that one of the hardest things, at least that I have seen with these types of conversations, is that everyone's automatically on defense, right? Everyone is automatically, well, I'm not a racist, and or this or that, and it is really hard to get through to the other side if they're already on such a defense. You know, you shut down that trauma, a part of that trauma response is, setting up a wall so you don't get, constantly hurt, and no one's telling you that you are a racist. And that has just become such a bad word, right? As if instead of something that just is, right? It is. And I think we have stayed away for so long from using these words that describe situations in order for us all to feel better and good about ourselves, that now when they are mentioned, it really it gets to the emotional part of our brain and not the rational part of our brain. And when we react to the emotional part of our brain, then we're not listening to hear or understand or learn. So I think just acknowledging that is helpful, and it's a big first step.
I'd just like to add, as we're running close to the end, Dr. Walker Harding's chat of how do we prepare us all for the long haul ahead. And my greatest fear is, yes, you know, things have changed over the last week, but as most of us in this work already know, I mean, this COVID is really just highlighting what we all already knew. It just has gotten its attention. So when COVID leaves and a new administration takes over, do we all settle back into our chairs of comfort? The families I serve really, COVID is not much of a hurdle for them. I mean, they have struggled for food, housing, safety, and they're doing that now. Like when I ask them how they're handling this upside down world, their worlds are already upside down. This is not really that hard. Like for me, in my sense of routine and privilege, this has been really hard for my kids and for my family, but the families, so we can't forget this. This work has to keep going, and it has to change. So please don't just close the book when January 20th comes, please.
Michelle Terry, thanks so much for helping me find the word that I was trying to find, like meeting these conversations with curiosity. That was the curiosity was the word I was looking for. So I appreciate it. I need to suck down my breakfast tea. I agree, Christina. It's such a great question of how do we dig into this work for the long haul. I'm not sure that I have an answer to that question other than most of us on this call most of us in this presentation don't feel like we have any other choice. I mean, this is the way that I've chosen to practice my professional career for the rest of my life and have done so for 15 years now. And I mean, part of it is a lived experience. Part of it is that I identify as Black and Native, but part of it is that there is no other way for me to practice medicine. I cannot see a future that does not involve serving my community and fighting until my last breath for them. So I think it's a great question, and I think self-care is really important, but I don't see an option. Well, I'm seeing some really great intentions in the chat. I really thank all of you for sharing so much. It's really, really awesome.
Yeah, I was just going to say that it's really great to see that. And I cannot, I think it's Laura Sim who said that it's up to the job of the white allies to carry the load. And I think it's our collective job, but I think it's really important to realize when your voice is more powerful for whatever reason, and acknowledging that and sharing that. But I think it's always important to kind of center it and say, why am I talking, and why am I not talking when we are having these discussions? And if you're not talking because of discomfort, then it's really a chance to step up. And if you are talking because you are so comfortable that this does not affect you, then it's really a good chance to step back and say, who is not talking, and how can I help support them in whatever way.
I think Suzanne's going to make us wrap up.
Yes.
Oh, I mean, I don't want to stop this conversation because it's so important, but it is 9:01. I really, really appreciate everyone's work. Everybody's comments in the chat are so powerful. And the four of you, thank you so much for taking the time to bring attention to all of your work, and all of us have, we'll be thinking about this throughout the rest of the work that we're doing. So thanks everyone for being so engaged. Thanks to the 4 of you for everything you're doing and for being here, and for our audience for sticking with us. And we really, really appreciate you. So thanks. I think we can continue this. It looks like there are some resources being offered, especially in terms of PPE. So we'll send you everything in the chat so that this can be followed up in the future. So thanks everybody. Thanks to the 4 of you. And everybody else, have a good Thursday.
Yeah, thanks everybody.
Thank you. Talk to you guys soon.
Juliana, if you're still on, maybe not be. I'll try to connect you with Christina and Fabiola.
Yep. Thank you for the offer, and thank you for the opportunity to talk today.
Thank you, Shaquita. It's Ellen.
Oh yeah, absolutely. I've got some emails to send now.
I know. We just gave you a bunch more work. Thanks. Sorry the end is so awkward, you guys. Thanks again. We really appreciate this. I'm so glad we could do this.
I just like to think of people coming up to the microphone stand as it used to happen.
I know, me too. Right. And then you'd be there till 10. I can't wait till we can do that again.
No, I kind of I kind of miss getting dressed.
I just started missing that. Yeah. That's how long it took.
I know. Me too.
Someday soon.
Yeah, someday soon. I think it was fall maybe that did it for me.
Yeah.
Yes, the change of seasons. I know. When we see each other again, we're gonna put in all the effort.
Yeah. With just full glam. Just
you look forward to that. Yeah.
Like it's the Academy Awards. Just like go all out.
I'm gonna bring my camera.
We'll need a camera because that's the only time I ever get dressed up.
Same. I'm doing it for you. All right. See you guys soon. I hope. Thank you so much.
Thank you.
Okay. Have a good week, you guys.